Chers participants, avant de donner les mots de bienvenue, je vais vous laisser savoir qu'il y a l'interprétation. Cette session sera donnée en français et en anglais. Dear participants, before starting, just to let you know that you can choose the language in which you want to hear this session. We have two languages, French and English. On behalf of the World Health Organization, good afternoon to all the participants, wherever you are joining us from. It's my great pleasure to welcome you to this important webinar on infection prevention and control and water sanitation and hygiene for mpox. I'm Dr. Landry Kabego. I work with the WHO African region, and I'm in charge of infection prevention and control for the African region. As you know, in August 2024, the WHO Director General declared mpox a public health emergency of international concern, underscoring the need for coordinated efforts to mitigate the spread of this disease. Countries have developed plans, they have mobilized the resources, and they have started to implement interventions to mitigate the impact of this disease. And among the interventions implemented, there are infection prevention and control and WASH interventions in healthcare facilities, but as well as in the community settings. Today's session brings together a diverse group of IPC professionals and focal points from WHO country offices, national and subnational levels, I hope from healthcare facilities as well and treatment centers. Whether you are representing an affected country or preparing for in the readiness phase, your role is pivotal to the success of this response. This webinar will therefore serve as a platform to first highlight the technical guidance and tools that are available from the WHO, to strengthen IPC and WASH measures for mpox. Secondly, this webinar will facilitate discussions on practical implementation strategies at national, subnational, and local levels. We'll have the privilege to have with us experts from the WHO headquarters, but as well as from WHO Afro and as well from UNICEF. The insight from these experts will really guide our understanding of these critical areas and inspire actionable solutions. So I would like to thank the speakers, the panelists, and all the people who made this possible, and to encourage everyone to engage actively during the presentations and the panel discussion. So your questions, your ideas, and experiences are invaluable to enriching these collective efforts. Thank you. And the session is opened. So on the agenda, I will be the moderator. As I said, my name is Landry Kabego Stiambagnan. I work with WHO Afro. And we'll start with some polling questions, and then we'll have a session on IPC and WASH in healthcare facilities that will be facilitated by Lassina Soro and Noshin Usman. After that, we'll have other series of polling questions, but as well as panel discussions and Q&A. And then we'll have another session moderated by Victoria Willett and Lushin Usman. And we'll finally have the last polling questions with another panel discussion and Q&A. Next. So before we start, please note that this virtual training adheres to the Code of Conduct to prevent and respond to sexual misconduct, including sexual harassment, abuse, and exploitation. Next. During the Q&A, you will have the option, as you can see here, to raise your hand. We encourage you to have your microphone and camera disabled. And also we will have the option to ask questions and to write something in the chat. Next. So for the Q&A, it's when you want to ask a question related to the topic that we will be discussing today. But for the chats is when you have a comment or question or query around the logistic, the IT issues, etc. Next. We have two languages, English and French. There will be direct interpretation. And this slide shows you how to access to the language of your choice by clicking to the interpretation icon and then choosing your language. If you don't directly see the interpretation icon, you can click to the icon where you see more, that is written more, and you'll find there the interpretation icon. Next. So this session will be recorded. When you participate to this session, it means that you consent to be recorded. And the products from this discussion will be shared on YouTube. Next. Thank you. So we will start with the first series of polling questions. Mr. Jacques, can you confirm that the polling questions have been launched?
Yes. And I think everybody has already responded because they were displayed from the beginning of the webinar.
Okay, this is noted. Next slide. So these are our speakers and panelists. We have Dr. April Bala, who is leading infection prevention and control in WHO. So maybe I will give the opportunity to each of the speakers to introduce themselves. Over to you, April.
Thank you. Can you just check that you can hear me okay?
Yes, I can hear you.
Oh, thanks, Landry. Sorry, I couldn't see you there. Yeah, so pleasure to be here today for this really important session, this webinar. My name is Dr. April Baller. I lead the IPC and WASH team within the WHO Health Emergency Program based in Geneva. So thank you very much, Landry, and back to you.
Lassina, over to you.
Thank you, Landry, and good morning or good afternoon, everyone, depending where you are. My name is Soro Lassina, part of WHO Health Emergency Program, IPC Technical Officer at HQ. Over to you.
Noshin?
Hi, good morning, good afternoon, everyone. I'm Nosheen Usman. I'm working as WASH specialist in emergencies with the WHO headquarters World Health Emergency Team. Over to you, Landry.
Victoria?
Hi, good morning, good afternoon, everyone. Victoria Willett, IPC consultant with the WHO Health Emergencies team from HQ, currently based in Canada.
Thank you, Pierre.
Good morning, good afternoon, colleagues. My name is Pierre Vauger, and I work with UNICEF WASH team at UNICEF headquarters, New York. Thank you very much. Happy to be with you.
Thank you. We have as well Babakar Ndoi, Prof. Babakar. Over to you.
Thank you very much, Landry. I'm Prof. Babakar Ndoi. I'm IPC consultant on WHO Afro. Thank you.
Thank you. Next slide. So from here, I will hand over to Vicky, who will okay, go previous slide. Maybe I will just give the objectives first. So we have two objectives. The first one is to highlight the IPC and WASH technical guidance and tools available for mpox. So there are quite a number of guidelines and tools that have been developed by WHO, disseminated, but we want to make sure that the dissemination was properly conducted, and that you are aware of the existence of these guidelines and the content of these guidelines. We will discuss as well as the second objective, the process of implementation of these tools and guidelines. What's our recommendation? And you, as the frontline health workers, you can also maybe suggest us according to your situation and your country or your area, what would be the best process to implement these guidelines and tools. Then we are going to go straight to the first presentation that will be given by Soro Lassina and then Nosheen Usman. Over to you, Soro.
Thank you, Landry, for the floor and the moderation. As mentioned by Landry, we are going to talk about IPC and WASH for healthcare facilities and treatment centers. What should be at the healthcare facility level and mpox treatment centers. So this is the strategy of IPC and WASH during mpox outbreak response. As you can see, the overall first thing is the coordination, which is the first component. Number two, we're strengthening the IPC and WASH to promote safe and scalable care. On that, we have focused on two elements, which is the healthcare facilities and mpox treatment centers. For that, the document that we are developing or that are already done are, the first one is clinical management and IPC for mpox interim rapid response guidance. This guidance was developed in 2022, but for your information, those guidance are under review and will be updated very soon. So the next one is the rapid assessment tool, which is already developed but not published, but has been used by some other countries already. And we have the rapid assessment tool user manual, which is also developed but not yet published. We are going to talk about it in detail during the presentation, following by the screening tool for healthcare facilities, and then the healthcare workers risk exposure assessment tool. We have also the posters, step to put on and take off PPE for mpox, and then the training material for healthcare workers and community health workers. The second focus is the community protection. the IPC and WASH team to promote and enhance community protection at 2 levels, which is the home care and isolation. And documents that have been put in place for that are the IPC and WASH measures for home care and isolation for mpox in resource-limited settings. And we also developed infographic for cleaning and disinfection of the home. So following by the community settings element, for example, the congregate settings, school, prison, or military camp, we have also developed interim public health advice for mpox-related prevention and control measures in school settings, which is already published, is available, and public health advice on mpox and congregate settings, already available. And then under development is the isolation in IDP camp. That document is under development. So the last component to focus here is the cross-pillar technical support for WASH and IPC. For instance, in the point of interest where people are passing a lot, it is important also to have IPC measures there. We also focus on the safe and dignified burial and the vaccination during mpox. For that, there is a document already under development for IPC during mpox vaccination operational guide. Next. So here are the recommendations for IPC from the document that been developed in 2022 for IPC and clinical management for mpox. What should be considered for IPC for suspected patient with mpox virus? The WHO recommends that contact and droplet precaution implemented for any suspected patient with mpox virus. In addition to contact and droplet precaution, airborne precaution should be implemented if varicella zoster virus is also suspected, like chickenpox, if suspected, until it is excluded. For the other consideration for the confirmed patient with mpox, so the WHO does recommend that contact and droplet precaution be implemented for any confirmed patient with mpox virus. In addition to contact and droplet precaution, respirator should be used. And the next recommendation for airborne precaution be implemented if AGP are performed, which is aerosol generating procedures. The next recommendation under the confirmed case is related to healthcare facility frequently used by the patient or where patient care activities occur and patient care equipment should be cleaned and disinfected as per national or fertility guidelines. The next recommendation regarding of patient linen management should be carefully handled and collected carefully. The dead fluid management for the body fluid management, which is for the mpox confirmed case, should be treated as infection waste. And the last one for the confirmed case is the measure to support the measures which will be implemented for the visitors to promote well-being. And regarding the management of the disease patient, the WHO recommends that handling of human remains of diseased individual with mpox should be done with appropriate IPC measures. And the last one is management of exposed health workers. As you know, WHO recommend also that for any exposure to mpox virus, the healthcare workers should be assessed and managed accordingly. But for your information, as I mentioned, this is the guideline for 2022, but it is under review and might be updated very soon. Next. So those here are the resources to support the implementation of the IPC guidelines. The first one we have put in place is the IPC and WASH strategy, which is the global strategy. Each country can adapt this strategy to their context to be implemented. The next one is the healthcare facility screening tool, which is already published. We are going to see it. The posters for PPEs is available, rapid assessment tool, and user guide, following by the health workers exposure risk assessment. And those resources we'll see one by one to see how they are linked to the response and how they are supporting the response. Next. Here is the screening form for healthcare facility entrance. This form was requested by a member state, especially from AFRO, in collaboration with the HQ and AFRO and partners. So the WHO has developed this tool, which intend to be used at a healthcare facility level, at the entrance of the healthcare facility, to screen all people that is entering the healthcare facility, including healthcare workers, patients, visitors, caregivers, everyone. And it is a tool that will be quickly managed to isolate cases. Next. Next slide. So the objective of the tool, as I mentioned, is quickly to identify potential suspected cases of mpox and put IPC measures in place so that the case can be safely managed and don't enter the whole healthcare facility to spread the disease. So, and for the IPC team, is important that if this case is identified, and the suspected case should be kept at safe distance, at least 1 meter from others, with a mask on and a separated room with adequate ventilation. Next. These are the posters that talk about. Here is the poster, the step to put on the PPE for mpox. It is already published and available. As you can see, the link below. It's available in French and English. Next. The next one is the step to remove. It's also available in French and English. It's accessible everywhere and you can use it. You can put it in your healthcare facility display so that everyone, all the healthcare workers know about the PPE, how to put on and remove. Next. Here is the rapid assessment tool, IPC and WASH rapid assessment tool for healthcare facility that I mentioned at the beginning. It is the updated version. As you know, in August, when the WHO declared the mpox as international concern, so AFRO and HQ has worked with the partners, other partners, and developed these tools, and it has been sent already to some of the countries that have been using it. And now we have updated the version. This new version has not been sent in the field so far, but is contained 16 thematic of IPC areas, which include the leadership, the training, the hand hygiene, the screening capacity, isolation, PPEs, injection safety, environmental cleaning, and WASH component as well, which is the sanitation, water supplies, storage, waste management, and management of disease and patient. But the assessment tool, the whole objective of this assessment is to identify the gaps and address those gaps. So we recommend that after the assessment, so the healthcare facility with the IPC focal person and the assessors to develop and implement an improvement plan according to the score. If the score is less than 50, so the facility will develop and implement an improvement plan, monitoring the facility once a day, which is every day, and reassess the health facility after 2 weeks. If the score is between 50 and 79, still you need to develop and implement the improvement plan and monitoring the facility every 2 or 3 times a week, reassess the facility after 3 weeks. And then if the score is 80% and above, still you need to develop and implement the improvement plan, monitoring once a week and reassess in 4 weeks. So ideally, the score of the assessment should be 100%. This is what we are looking for. Because these two, if everything is fine, the score should be 100%. If the score is not 100%, no matter is the score, there should be an improvement plan to be developed and implement to address the gaps as been identified. Next. So here is the user guide, as I mentioned. So the user guide provides instructions to those individuals who are conducting the IPC assessment at healthcare facility, because before you use the tool, it's important to have the user guide, because the user guide will tell you how to score. The score is yes or no. But before you give yes or no, you should understand the indicator you are assessing, if the facility meets the indicator or no. But there is a instruction to tell that this facility met this criterion, otherwise is no. But we encourage that this user guide will soon be published and everyone to have to read it, to understand it before you do the assessment. He will help you to understand the scoring system and also to better score and have a very good score, which is reflecting the reality of the healthcare facility. The next slide. So here's the last tool that I will talk about, which is the risk assessment for health and care workers with a potential occupational exposure to mpox virus. This tool is used to assess all healthcare workers that been exposed in healthcare setting. It could be healthcare facility level or in mpox treatment center who have had an occupational exposure to a person with mpox. And the tool also determines the risk categorization of the healthcare workers who have been exposed to the virus and inform the recommended clinical and public health management of exposed health and care worker. But one thing is important here for the tool is that before you start the assessment of this, make sure that the healthcare workers did not start developing the sign and symptom of mpox, because if it's already developing sign and symptom, there's no need to do this assessment because it's already a suspected case. So it is important that to really make sure that the assessment is done when it is the sign and symptom has not started. And also inform them, the healthcare workers, that this assessment is not for other things, but is to help them to protect themselves, to protect their family, their co-workers, and their patient. And it is not used to penalize the healthcare workers. Next slide. So here is how to manage the health worker exposure. If a healthcare worker is exposed, how is the management? So it's to provide you that the guidance for management of the healthcare worker based on the determined exposure risk. But the IPC focal person from the healthcare facility or the occupational health and safety focal person should notify the relevant public health authorities of the possible exposure. The health and care workers should undergo medical intervention or immediate consideration for possible intervention, because it could be the vaccination, to be the recommendation, or post-exposure prophylaxis could be the recommendation. But for
Can wrap
mpox,
up?
okay, for mpox, I'm almost finished. Okay, thank you so much. Over to you, Nishin.
Thank you so much, Soro. Can you confirm if you can hear me?
We can hear you.
All right, thank you. Thanks to Sora for giving us the overview of the IPC tools and available guidelines. This is just a snapshot of what are the documents available for WASH in healthcare facilities improvement. So the first I will talk about the WASH Fit tool. So we have the open WHO course available, which can be used both by IPC professional, WASH professional. If you know, you can also disseminate these tools to the partners. So this is already available on Open WHO. And as Soro has mentioned, we have the IPC WASH Rapid Assessment tool already available to assess the WASH services, basic WASH services that are required in health facility who are providing care for the mpox patients. WASH Fit will, in case that that there are WASH services improvement required, WASH Fit tool can be implemented in addition to the IPC RAT tool, because it gives you a quick overview. IPC RAT gives you a quick overview of the WASH services availability, and WASH Fit tool, it helps in implementation and to dig down deeper into the what kind of WASH services, how it can be improved. So it's a full package that can be implemented. Other guidance notes in the documents on safe waste management are available in Essential Environmental Health Standards, which gives an overview for all the WASH services availability within the healthcare facility, including waste management, as well as vector control. And then we have also which usually comes during comes up during the mpox response, is the waste infectious and sharps waste management from healthcare facilities. So this is the document which talks about even the resources and technologies that can be used in low resource settings. So this is another good resource, technical resource which can be used. I'm also sharing here the link of the partners platform talking about the essential IPC and WASH kit for healthcare facilities, listing out the key items for IPC and WASH, so that can be used by the colleagues at the country level. Next slide, please. This is just a brief background of what are the key WASH services that needs to be available in terms of water supply, and water quantity and quality, sanitation, hygiene, and environmental cleaning and disinfection, as well as waste management. So for the water supply, there is no key standard available for mpox, but to adopt and to understand the needs of intensive environmental cleaning and disinfection, laundry management, and what for which the water would be at least minimum 60 liters per day liters per patient per day should be available within the health facility. And if we see that there is intermittent water supply within the health facility, so the minimum storage capacity should be for 2 days for the designated, for the targeted healthcare facility. Water quality monitoring is important, not only that it ensures the drinking water safety for the patients and for the healthcare workers. So that should be also considered, as this is also part of the IPC. That too, for sanitation, there should be a dedicated toilet for the confirmed and suspected patient. However, if it's shared among the confirmed patient, that it intensify the environmental cleaning and disinfection activities, we have suggested that it should be 4 times per day if it's shared among patients. And for the routine, for the concentration, if it's as we have seen that the study has an evidence of that 0.05% of the chlorine solution is effective for surface disinfection with 1 minute of contact time. However, we suggest that routine environmental cleaning and disinfection concentration should be adhered within the health facility. So other pathogens can be targeted because this is lower for other the concentration for other pathogens. And the same procedure would apply for shower use and availability of hand washing services with soap and water or a BHR solution or waterless soap in case there is limited water supply availability within the health facility. For environmental cleaning and disinfection, so as I said, that routine environmental cleaning and disinfection procedures should be applied within the health facility as per national guidelines, and and PPE it's required for the cleaners. So it's listed down there that what kind of PPEs is required. And also dedicated footwear that can be decontaminated and the shoe covers are not recommended. And then also training of environmental of cleaners as well other relevant staff should be conducted on a regular basis. For next slide, please. On the waste management, so for the waste management, availability of waste segregation, collection, and transportation supplies and equipment should be made available, and it should be part of the improvement plan in case there is a need, and also availability of SOPs for hazardous waste collection and storage as well, as we see that there is human-animal interface linkages that this virus can be spread. So we need to make sure that the infectious waste is stored safely away from public as well as from animals. So that's very important. And then performance of hand hygiene, intensive hand hygiene after handling the waste, and to make sure that the SOPs are available for waste management. For treatment, and also we need to consider in low resource settings, as I've shared other links and documents, if in case there is no proper waste disposal treatment facilities available, there should be SOP for infectious waste hazardous handling, as well as for transportation and final disposal if it's offsite. That's all from my side. The next slide, I think it's the questions.
Thank you so much, Lassina and Noshin. So we had two great presentations. Now we have launched the second series of polling questions. Just read the question and respond as you can. So maybe I can read the first question of the polling. Which of the tools presented were you already familiar with? Okay. The second is, which tools presented do you think would be the most helpful in your role? Okay, and then the last one, what additional tools would help you in supporting IPC in health facilities and treatment centers? So if you think that there is a tool that we need to develop, don't hesitate, just write it, and then we can see how to work on it. So the last polling question is, okay, there are six questions. Okay, make sure that you answer to all the 6 questions, please. So we'll give you a few seconds to finalize all the 6 questions. Make sure that you are answering to all the questions. Meanwhile, I will thanks to Lassina, who gave an overview of the different tools and guidance documents that have been developed for healthcare facilities, for home care, for the community settings like the schools, the congregation. congregate settings and the IDP camps. And then there are some guidance documents for that have been developed in collaboration with other pillars like the vaccination pillar. I think Lassina really insisted on the rapid assessment tool for healthcare facility, which is a tool that helps you to assess healthcare facilities on IPC best practices to develop an action plan and then to implement this action plan before reassessing the healthcare facility. So that was something that he really insisted in. Also, he shared with you the screening tool at healthcare facility level, where you have to screen everybody who is entering in the healthcare facilities. He shared as well the posters, their training materials as well. And there is a tool for risk, for assessment of the risk of exposure of health workers. So for the home care, there is a tool as well. There is a guidance document, but as well some guidance for cleaning and disinfection. So Noshin insisted on the existing WASH guidance, like the WASH feeds, the documents on technologies for treatment of infectious sharps, etc. And then she gave us an overview on the recommendation in terms of WASH in healthcare facilities. So now I will open the floor for the panel discussion and then the Q&A. So there are some questions that have been asked in the chats. So I will give the floor to the panelists to respond to some of these questions. I think there is one question asked by Dr. Raphael Okum, who is from DRC, is the IPC focal points for WHO in DRC. And I will translate his question, which was asked in English. I will translate it. It was asked in French. I will translate it in English. Concerning the guidance on doffing PPEs, how do you justify the removal of the gloves before the other PPE, like the gown, the medical mask, and others? Is there not any danger in removing the gloves before the other PPEs? This can maybe lead to an exposure to the fact that the other PPE are contaminated. So maybe April?
Yeah, thank you, Landry, and thank you, Raphael, Dr. Raphael, for the important question. So it's precisely because they are the most contaminated that they should be removed first. So remember, with the principles of removing the most contaminated to the least, that's the kind of the principles of IPC. So that's why we remove the gloves first. That's the reason for it. There are sometimes discussions to remove the gloves and then the gowns, and sometimes the gloves and gowns are removed as one. It's the most important thing is the initial removal of the gloves. So whether that goes combined with the gowns or not can vary, but just to say that it's because of the contamination that's there. I hope that's clear. If anybody else wants to come in and add anything from the team, please do. Over to you, Landry.
Thank you so much, April.
Je peux ajouter quelque chose?
Yes, go on, Prof.
Ok, c'est juste pour dire que le fait d'enlever les gants en premier lieu, d'abord, on peut l'expliquer par deux choses. Il y a un moyen d'enlever la blouse, d'enlever les masques, on les prend par derrière, qui est la partie la moins contaminée en principe. Mais surtout, la deuxième explication, c'est qu'après, il faut faire l'hygiène des mains avant de passer à autre chose. Ce qui fait que on reprend avec une main complètement désinfectée. Merci.
Merci beaucoup, Prof. Babacar. S'il y a des questions, if you have any question in the room, please raise your hand and we will give you the floor before we go to the next session. Si vous avez des questions, vous pouvez cliquer sur l'icône ou pour lever la main. Et puis oui, on va prendre une question, celle de Ousmane Fofana. À vous. Vous pouvez lui donner la parole, s'il vous plaît, Monsieur Jacker.
Allô, bonjour à tout le monde. Je suis Dr Fofana Ousmane de la Croix-Rouge guinéenne. Je voulais poser une question, c'est par rapport à l'inhumation des corps des personnes décédées de la maladie. Voilà, j'ai dû entendre par là qu'il faut réaliser les enterrements dignes et sécurisés. Est-ce que, comme à l'accoutumée avec Ebola par exemple et les autres, mais comme on est dans le mpox, est-ce que c'est les mêmes précautions de protection? Il faut utiliser aussi de la combinaison, et aussi des autres équipements de protection, typiquement comme l'autre fièvre hémorragique. Merci.
Merci, Monsieur Dr. Ousmane. So Ousmane is from the Red Cross in Guinea, and he wants to know if we should use the same precautions for safe and dignified burial in mpox as those ones that we use for Ebola, for example, using the coverall, etc., and all these Ebola precautions. So this is his question. Any of the panelists? Yes, Soro, you want to go ahead? You are muted.
Ouais,
Unmute
Ousmane,
yourself.
merci pour votre question. Je vais répondre en français comme vous avez posé en français. Bon, la réponse est d'abord non. C'est pas la même chose comme pour Ebola, où on va prendre la combinaison comme l'épi entièrement. Ça, c'est d'abord une différence. Deuxièmement, pour le cas des mpox, ceux qui sont décédés de mpox, il n'y a pas de sac mortier systématique qui est utilisé pour faire l'enterrement. En fait, le corps, si la personne est décédée à l'hôpital, est préparé par les équipes formées pour ça, je veux dire PCI formées. Le corps est préparé avec les équipes portent les épis qu'il faut pour préparer le corps et le remet calmement aux parents et peuvent assister à l'enterrement, mais il n'y a pas de mesure, je veux dire en termes de sac mortier où il n'y a pas de combinaison à mettre pour s'occuper de ce corps. Et il n'est pas conseillé même de faire la pulvérisation. Tout ce qu'on faisait dans le cadre de l'Ebola n'est pas vraiment la même chose ici pour le mpox. C'est quand seulement si ce corps fait des fluides corporels qui dépassent les limites, alors en ce moment, on peut utiliser le sac mortier. Ça, c'est des cas exception. Donc, d'ailleurs même, parmi les épis de mpox, on ne recommande pas vraiment le sac mortier systématique. Je pense que les autres vont me compléter un peu.
Merci. Thank you so much. April, you have?
Yeah, I think maybe
comment?
just know it's very comprehensive. I think the only thing to add is they don't need to be using the coveralls, right? Is the PPE should be the same PPE they use to manage the patients if and when they need it. So it would just be the gowns with the gloves and the mask, just to add that. Thank you. Over.
Okay, thank you so much, April. So there is a question on WASH. This is a tricky question. So Pierre-Yves and Noshin. The question is, I saw the question, where is it? Okay. Okay, maybe somebody has
I can read it out to you, Landry, if you want.
Okay, go ahead. Yeah.
It's from Safel Mekone, and it is good to have this 3 types of waste segregations, but as you know, in resource limited setting, there's no general waste management by the municipality. So where do we treat this general waste? So maybe over to Pierre-Yves and Oisin. Over.
Thank you very much. Well, very good question. And as you say, Landry, a complicated one. Indeed, we do not have always the local capacity we wish to treat and dispose of safely. The alternative that is proposed in WHO guidance is to if this is not available, then to dig or bury and or burn. But on top of that, what is important, I think, to consider is also how to minimize the waste that is produced. So how, in a first stage, we can minimize the amount, and as part of the treatment, ideally, we wish that it could be well, first segregated, but then treated and disposed of safely and by the municipal authority is not feasible. If not feasible, as a recommendation is to dig or to burn on a local basis. Over to you, Nashin, if you wish to complement. Thank you.
Thank you so much, Pierre-Yves. As I understood, the question was, I think, about the journal waste disposal. So if we segregate waste, the infectious waste is quite in limited quantities that can be treated and disposed of safely based on the local or WHO guidelines available, such recommendations. For the journal waste, we do not consider it as infectious waste. So it can be disposed of with the municipality waste. If there is no centralized collection, then I think the hospitals usually have a mechanism to dispose of journal waste. So it would be considered as the same. So if I understood the question right, I think it was more about journal waste treatment and disposal, not the infectious waste. As already Pierre-Yves has mentioned, that what are the mechanism or options available for infectious waste management on site at health facility level.
Thank you for the clarification, Nashina. I wasn't sure about the question. Thank you.
Thank you so much, Noshin and Pierre-Yves. April, is any other question in the chat that we can consider at this point?
I think there's another question around limited resources. It's about the treatment of linen in the centres de santé avec resources limitées. So, yeah, I mean, I think it's a good one. And I think the good news is, and I'll start and please other colleagues come in, is that the good news is that the mpox virus is deactivated or inactivated quite easily, even though it's contagious. So it only needs 0.05% chlorine to deactivate it. So with limited resource, I guess the point is normally if it would be washed at higher temperatures, then it can be with soapy water, then that's usually sufficient, but that means you need a machine. So if you don't have a machine, the idea is they can wash it in cold water with soap, and then they can dip it in chlorine. And if I remember correctly, that's 0.05, but I just want to check with others online if they remember the exact concentration. But I think that's it. So it's relatively easy to do. Even in resource limited settings. But can I confirm, I don't know if one of the other panelists, they have the exact concentration of the chlorine?
Yeah, there is a Vicky.
Yes, you're correct. April, the minimum concentration that's needed is 0.05%. And that's for both. It will work. It's effective for laundry and it's effective for most environmental surfaces as well if you're cleaning and disinfecting. But I think I just want to reiterate the point Noshin made earlier, that is the minimum concentration, but that's not necessarily effective for all pathogens that may be circulating in a hospital or health facility or treatment center. So if you're already using a certain concentration of a disinfectant, you don't necessarily need to change it. But if you're not using something, then at a minimum, you should be using 0.05 for the monkeypox. But I think that's a really important point that Nosheen mentioned earlier, and I'm not sure if people caught that. So if maybe you also have cholera circulating in your area, so you're using 0.1% chlorine. We'll continue to use that, knowing that it will be effective for the mpox virus as well. So just want to highlight that.
Yeah, Vicky, I think that's critical. Thanks for that. And I think the only other thing maybe to add, Landry, is that I know we're speaking here about the facility setting, but in the home setting, that would be okay to use the 0.05% if they have to clean in the house of homes. So one thing is a health facility setting and the other thing is a home setting. And of course, the lower it is, the less risk of any side effects to the people who are using the disinfecting. Thank you. Over.
Thank you. I have a question, a quick one. April, if the health worker tested positive for mpox and has returned to work, is it possible to conduct a risk assessment? This is from Dorothy.
Yeah, so that's also a good question. So there's two elements to health workers. One is around health workers who are exposed to a case, so they're a contact. And that's when we do the health risk exposure assessment that Soro Lacina presented is around that. And then there's the management of health workers who actually are infected with mpox. So if they tested positive, then they should follow whatever the local policies are on management of health workers who are infected. And usually is that they should be treated as a normal case, but it can potentially vary from one country to the next. So I hope that's clear, but if not, please anybody else add on to that. What they do need to do is the context of that health worker need a risk assessment. So if the health worker is infected and the infection happens, it can happen in the community, it can happen in the facility, but it will be important that if it's in the facility, the other health workers who've been exposed from that health would need a risk assessment. I hope that answers the question.
Yeah, I think it's clear.
Just to add maybe, Landry.
Yes, go ahead.
If the health workers is positive, it is also important to know why and how it has been infected to avoid next infection.
Yeah, sure. Yeah, sure. That is the investigation. They can do a deep investigation of the positive health worker to see what were the risk factors that led him to be infected. Okay, I think we have gone through almost there. We still have just one question before we go to the next presentation. And I just want to let you know that we will share the material that we have presented today, that we are presenting today. So the last question that I think we should respond to is from Stoic, who said that if we have healthcare facilities that obtain 100% in the assessment using the rapid assessment tool at the first evaluation, and then at the following evaluation, the facility obtain less than 75%, what should we do?
Thanks, Landry. I could start on that one. So
sure.
Thank you for the question. So first of all, any health facility that obtains 100%, really want to congratulate them. And one, I would really also think about, did they, just to be assured that they really received 100%, but it's very difficult to achieve that. Normally, as Sora Lucina was presenting earlier, the target is 80% or above, but it's very unusual for a health facility to actually reach 100%. However, if they were to do that, and then the next time they obtain 75%, that's fine. That's the reality. And there could be, reasons for that. Maybe the health worker who's the IPC focal point has moved on. Maybe the supplies, are depleted, etc. So what they need to do is with that result, they should follow the scorecard or the rapid assessment tool that explains, depending on what the results are, what the follow-up should be. So the follow-up for 75% would be that they need to do an improvement plan, identifying where the gaps are, work on that, and then do a reassessment within three weeks. And they should have supportive supervision in between that reassessment, usually either 2 to 3 times a week. So hopefully that's clear, but please, colleagues, anyone want to add anything to that? Over.
Thank you, April. I think the explanation were very accurate, and welcome to Dr. Christine Lundry-Densikira from DRC, the Ministry of Health, to this session. Over to you, Vicky, for the next presentation.
Thanks, Landry. And thanks everyone for all the really interesting questions in the webinar today. So now we're going to switch focus a little bit, and we're going to talk about IPC and WASH for mpox in the community settings. And I want to start by highlighting, again, going back to the guideline that was published in 2022, that while there was many recommendations around healthcare facilities, there were also recommendations for persons staying home with mpox, because there are some situations where a person may not be very ill, have a few lesions, and meet the criteria for staying at home and being cared for in their home setting. So we had a number of recommendations around that, talking about that they should have a home assessment, that they need to have the right things in the home in order to be able to be safely cared for, and that they may need to have a caregiver appointed that could help them care for themselves. Ideally, they can provide their own care, but that may not always be the case. And then a lot of information around handling linen and cleaning and disinfecting of the home, which April has already briefly mentioned. So with that, we also provided in that guideline a pathway, an algorithm for decision-making on whether or not the person meets the criteria to be safely cared for at home. So we want to make sure, of course, clinically that they're stable enough and well enough to be at home, and that they have the things they need in their household, which is this checklist for IPC conditions, in order to be cared for at home. So that is in the back of the guideline. However, as this outbreak has evolved, and now with the new public health emergencies that's been declared, things have changed a little bit. And we're seeing a lot more cases in more resource-limited settings. And so this fall, we published a guidance document for infection prevention control and WASH measures for home care in resource-limited settings. And the purpose of this document is for community health workers who may be supporting people in their home, and clinicians, for the persons with mpox and caregivers at home. And it also talks about WASH requirements. And the purpose is to provide what are some alternative options that could be provided if your resources are limited, that can still help you to be isolated and managed in your home setting. And so we're going to talk a little bit about that in detail. So there's, as I mentioned, information for the community health workers or providers that are supporting the family at home. There's going to be some infographics that we want to provide for caregivers and the family members themselves, the person with mpox, and the posters for PPE for any community health workers that may be going into the homes of persons who are being isolated. It's the same posters. They're still following the same PPE requirements. So I'm giving you a little snapshot as just an example of what's in the document here. So here we have some statements. For example, any health and care worker that's going into the home of a person with mpox should be wearing certain PPE, the appropriate PPE. So gown, gloves, respirator, and eye protection. And if they're within a meter of the patient. However, let's imagine you're in a situation where there's community health workers trying to support people at home, but you don't have the PPE. So how can we manage that? Well, then we're suggesting that they, if the PPE is not available, then meet with the person outside. Stay outside the home. Maybe the person can stand at the doorway, the health worker can stay about a meter away, have the conversation with that family member or the person themselves with mpox, find out what they need to support them, and then you're not putting yourself at any risk. So again, it's about changing your approach to supporting that family so that you don't have to go into the household if you don't have the appropriate PPE. And so we go through all the different options in the document. Maybe you're the person with mpox, and we recommend that you remain in a separate, well-ventilated room in your household away from other members. But maybe your household doesn't have a lot of rooms and a lot of space where you can stay. So then we provide some other suggestions where perhaps you can find a designated space within the household, maybe put up a curtain or something to help identify that space so the rest of the family doesn't enter your space. And that if you have to be around other members of the household, to cover your lesions and wear a mask. What if you don't have a medical mask? You could wear a fabric mask. So we provide a lot of different options throughout the document to help you implement the measures to the best that you can in the home setting so that you can stay home and support the family members at home. Within the document, you'll also find some guidance on how to manage laundry in the household. We've talked a little bit about the fact that you can use the 0.05% bleach concentration at home as well, or warm water and detergent will also work, but it's important to do the laundry separate from others. We talk about cleaning and disinfection in the household, what PPE to wear. If the family members do not have PPE, maybe they can wear some household gloves and just wear the certain clothing that they keep dedicated for when they're in touch with the person with mpox. We encourage people to use soap and water and or household bleach at 0.05%, and just to clean and disinfect the surfaces on a daily basis. There's no need to go in and spray households. And this is also relevant for when the person comes out of isolation and their mpox is healed and they no longer need to stay on isolation, that the household can be cleaned and disinfected in all of the key areas where that person was. However, we do not need to send teams in to spray the household. That's not required. So we talk about that in the document as well. There's also sections on WASH services, and we talk about how much water is actually required. And while the recommended amount is 60 liters per person per day, at least 15 to 20 needs to be available. And you need to have some way of storing that water. So there's a lot of different recommendations for managing that, for boiling the water if needed, for drinking, for 1 minute, etc. So there is a lot of recommendations that spell that all out in this guideline. We also talk about what about if you have to share the toilets or latrines that you're using or the showers, how to go about cleaning those in between uses. And also talking about, okay, so now you have some waste at home. Maybe you have, most of it's not going to be needed to be managed as infectious, but some of it might be. And so you want to put it in a tightly closed bag and dispose of it either with municipal waste or whatever procedures you would normally have available to you, burning and burying it, maybe into a pit, that sort of thing. So that's described in the document as well. And to support some of these, this guideline, we are working on a number of tools and resources. And here we have some. So we have the operational guide that I just spoke to. There's public health advice on mpox for people living in camps and refugees. So that is a document that's been published with multiple partners. And then there's also this public health advice for mpox in congregate settings, but this is not specific to resource limited settings, but this has been published in the past. So those are available currently from WHO. And we're working on a number of other tools to support. I should just go back. I want to mention that we're also working on tools. I think my slides got a bit mixed up here. And infographics that we will be providing to support the home care guidance. Some public health advice for preventing mpox in schools was published by the African region earlier this fall in September. And this document, hopefully you're aware of it, provides advice for screening in schools, hand hygiene, communicating with the right people, the teachers, the students, the families. Talks about environmental cleaning and disinfection and how to manage a case if somebody is identified on school premises as a suspect or confirmed case of mpox. So within that document, there's also an essential list of supplies for schools. And this, as I said, has been published in September. So here's where I think my slides got a little out of order. Again, going back to the home care guidance, we are working on a number of tools to support this implementation of this document. Here we have an information sheet for community health workers. This is just about to be published, hopefully within the next week. And we are also working on translation for French. So it's a sort of a one-page document that covers the highlights of this lengthy home care document that a community health worker could just have as a quick reference on what they need to do to support somebody who's at home on isolation with mpox. And then along with that, we are working on, as I mentioned, a public health advice for home care in resource limited settings. And we are also working on a number of infographics that could be given to the caregivers and the person with mpox as sort of IEC materials that they could have that would tell them how to care for themselves and how to manage, cleaning and disinfection, laundry, that sort of thing. So those are in development. They're going to be a few more weeks yet before they're ready. And within the home care guidance, some annexes are included in the document that I wanted to take a moment to highlight here. There is the clinical consideration. So again, highlighting that assessment to determine if the person is eligible to be cared for at home, whether they're clinically stable enough and whether they can manage it. So that's within the document. And there's also an essential supplies list, and we have UNICEF here online as well because they have been supporting the implementation of making sure that families who are sent home to be isolated with mpox have the supply kits that they need to facilitate their isolation. So we are partnered with UNICEF to support that work. And then I'm just going to move on to talk a little bit about IPC and WASH during vaccination. As we know, this is a big piece that's happening now for the response for mpox. They're rolling out vaccinations campaigns for mpox. So we have developed a brief guide that's about to be published, hopefully in the next couple of weeks at the latest, highlighting what the IPC and WASH requirements are when you're doing vaccination activities. The document's divided into 3 sections, some information on planning for your campaign, some operational things, such as making sure you have supplies for hand hygiene, what PPE is needed, if any, noting that it's really, really important that we emphasize that standard precautions should be followed. The people who are getting vaccinated should not have mpox. Therefore, you want to make sure you have screening set up. And because they do not have mpox, there's really no additional PPE required. You would just proceed to as usual for vaccinations. And then we have some annexes in there with some sample daily checklists and a little step-by-step thing on setting up screening. This is a lot of information. So what we've also developed to support this document is, again, a little one-pager that's still being worked on for the health workers who are providing vaccinations with highlights for what they really need to know for giving vaccines during mpox. So this is all coming soon. And along with that, our WASH colleagues have developed an SOP for waste management because we recognize that there's a potential for a lot of waste to be generated during this process. And so they have provided an SOP that's about to be published for waste management activities during vaccination. As you can see here, they've outlined the different types of waste, what's infectious, what's sharps, your general waste. And I think an important thing here is what Pierre mentioned earlier around limiting the amount of waste. So there should be almost no infectious waste because For example, you shouldn't be using a lot of PPE, but you would be focusing on your any vial waste or sharps waste would be your main area in that respect. And they will also outline some of the treatment and disposal options as well. Lastly, we are working right now on some principles for IPC and WASH in isolation places that are being set up in many camps. We know in some areas, especially in the DRC, where you have a number of IDP and refugee type of camps, that even with our home care guidance, it's still challenging to implement isolation in the home. And some places are being set up for people to be isolated while they're recovering from mpox. And so to complement the treatment center design standards, we're working on some guidances around the principles of setting up such facilities in these types of settings. And that's going to be a few weeks yet before that comes out. So I'm going to stop there so we have time, hopefully, to go back for the polling questions and for any questions from our audience. Thank you.
Thank you so much, Vicky, for this great presentation. So the presentation mainly highlighted the different tools and guidance documents that have been developed, especially around home care, mpox home care, but as well as IPC WASH during vaccination campaign. So I encourage all the participants to respond to the polling question. This will help us to know your views about what have been published and what the step ahead to improve and which document we should focus on in the future. Please, Soro, is there any question in the chat that we can take?
In the chat.
In the Q&A, sorry.
Yes. Une question en français ici. Quelle approche à utiliser à l'endroit de la population qui détruit les dispositifs de lavage des mains et autres outils de sensibilisation comme les affiches publiques dans les communautés sous prétexte que le mpox est une épidémie imaginaire pour s'enrichir, orchestrée par les acteurs de la santé. La question est de Stoic. Voilà, Swedi.
Thank you so much, Soro. I think this is, unfortunately, we don't have any anthropologists or risk communication experts in our panel, but maybe I would give the floor to Pierre-Yves to try to respond, if possible.
Thank you very much, Landry. And actually, I mean, it's really not my field of expertise, but maybe what we can really highlight is the importance of community engagement and risk communication globally, and how much, and we see it more and more for each disease response. We need to ensure that we have the buy-in of the community, that we can address the key concerns. So we need to monitor what is being said, what is and to address the main issues. We do work a lot on this, and actually, as you said, UNICEF and WHO, we work on it together, but we do not have any of our colleagues here to properly answer to that question. But it's a complicated one, and we surely need to ensure that we address it properly, that we have a commitment from community leaders, that we build on the community leaders, on all our counterparts in the community to ensure that people does receive the right information and can actually wash their hands properly, and actually not not only for mpox, but all for all hygiene purposes. So that's all the way I can try to handle with this question. And back to you, Landry. Thank you.
Thank you so much. I saw a hand from the participant. You can raise your hand, please. Vous pouvez lever une main si vous avez une question à poser. Please.
Landry, il y a une autre question qui est un peu semblable à celle que Pierre-Yves vient de répondre. Cette question est de José qui demande mpox et les soins à domicile. Je pense que c'est une façon d'augmenter la propagation de la maladie dans la communauté. Bon, c'est un commentaire, hein? Je ne sais pas si...
Well, maybe I will invite José. Can you speak up? Can you raise your hand? Then, José, vous pouvez lever votre main, comme ça on vous donne la parole pour nous expliquer un peu votre expérience en ce qui concerne la prise en charge à domicile de patients avec mpox. Levez votre main, s'il te plaît, José, pour qu'on vous voie et puis on vous donne la parole. Parce que nous pensons que le point que vous venez d'aborder est un point très essentiel.
Oui, avant José, je termine par une autre question qui est posée par Augustin Karumba. Quelle est la meilleure procédure de désinfection pour les maisons en terre battue?
Okay. Vicky, what is the best procedure for disinfecting the houses with mood surfaces? Yeah, I think that's it. Yeah.
I'll start and then ask any colleagues to join in. So again, I think we have to be careful here not to focus on disinfecting the entire house. So we don't need to be trying to disinfect walls and things like that. What we're talking about is cleaning and disinfection of things that are touched by the person or the space where that person who has mpox is staying within the household. So, and there may be some ways to prevent some of the contamination of the surfaces. For example, if they have a particular chair that they're going to sit in, cover that chair with a cloth if you can, and then when that person's no longer infected, they can remove that cloth, wash it as separately as laundry. And because how will you clean and disinfect a cloth chair if that's something they're sitting in, if they don't have a plastic or other types of chair? So what we really want to focus on are the things, the places the person has potentially touched or sat or stayed, and not so much looking at trying to disinfect the entire household, because that's not necessary. If anybody else wants to compliment Prof or April.
Yeah, I think the only other thing is I thought I heard something about porous surfaces, Landry, and if that's the case, I think we all acknowledge the challenge of disinfecting. So first of all, to remember, it's clean and disinfect, not just disinfect, cleaning first before disinfection, but acknowledging that it can be very challenging to be able to clean and disinfect porous surfaces, and really it's the methodology of doing the cleaning and disinfection shouldn't change even if it's porous surfaces. You still want to do your wiping methodology. So I think that's just wanted to add that, but appreciating particularly if the porous surfaces is also soiled, and that's for that reason you would need to have multiple wipes to be able to do that properly. I hope that's clear, Landry, but if not, anybody else wants to add anything? Over.
No, that's super clear. So we are going to give the floor to José Lolekoleko, who is going to speak a little bit about his experience on home care. But as well, there was the hand from Lassine. Lassine, keep your hand up. Lassine, vous pouvez garder votre main levée. Before I give the floor to Jose, please, Vicky, can you go to the first slide that shows the title of the webinar so I can take a screenshot, and if the panelists can put on their video. Over to you, Jose. À toi, Jose. Can you unmute, Jose? Help Jose to unmute, please.
I think IT says that the person who asked the question is disconnected.
No, he's there.
He
Oh, he is
reconnects
back.
again.
Oh, okay.
Yeah, he's back. His microphone is activated. He needs to just unmute himself.
José, vous pouvez activer votre micro, s'il vous plaît.
Is it Jose Pula? No. Can we unmute them?
Oui, ça pose problème.
Ah,
Ah, là, on
there.
vous entend. On vous entend, José.
Oui. Alors, je voulais dire ceci. Je dois féliciter le docteur pour sa conférence qui est tellement édifiante. Et à vous aussi, les traducteurs. Mais ici, je m'avais dire notre expérience pendant le COVID-19. On a eu à élaborer les critères pour le COVID parce qu'il n'y avait plus de place pour beaucoup de malades à l'hôpital. Et c'est comme ça qu'on a adopté pour amener ces malades à domicile pour qu'ils puissent suivre les soins. Mais les comportements à domicile, prenons chez nous en Afrique, on est souvent nombreux à domicile. Souvent, il n'y a pas de clôture, il n'y a pas de ceci. Et ça devient aussi un risque pour la suite de la famille. Et on a eu aussi des contaminations en cascade. Moi, je pense qu'au stade actuel, le mieux de retenir le malade qui est en isolement à l'hôpital jusqu'à la fin de la maladie, certifier que la personne ne peut plus contaminer, c'est à ce moment-là qu'on va le libérer à la maison. Mais donner la responsabilité à la famille pour suivre la personne, je pense que c'est la source de propagation. Comme vous le savez, dans nos toilettes, par exemple, que ce soit toilettes modernes, que ce soit toilettes traditionnelles, les gens vont toucher partout et en même temps, c'est une maladie qui se contamine par voie sexuelle aussi et ainsi de suite. Donc, moi, je pense que ça va donner lieu à la propagation de la maladie si nous encourageons les soins à domicile. Et on n'aura pas un membre de PCI, un cadre de PCI ou un agent PCI qui va rester avec le malade là-bas pour veiller. Mais si l'hôpital a encore de l'espace, je pense que c'est mieux de retenir le malade jusqu'à la fin de la maladie. Ça pourrait être mieux. Parce qu'on en a vu avec le COVID-19, je pense que ce n'était pas facile à gérer à domicile. Il n'y a pas de clôture souvent, il n'y a pas de ceci, il n'y a pas de ça. C'était un peu ça mon intervention, qui n'enlève à rien la valeur de sa conférence. Merci.
Thank you so much, Jose. I guess, Vicky, did you get the comments from Jose?
I think I got it. I had the translation on to help.
Okay.
I think he's raised a really important point, and that's why it is really important to assess the individuals and make sure that the home care can be successfully implemented, right? And we've got that in the clinical guidelines, and we have also mentioned it in the home care guidance. So they have to meet the criteria. There has to be the support. They have to have a mild case. So, for example, children under the age of 5 are high risk. It's not a group that we suggest goes home, that they should probably go to a treatment center. People who are severely immune compromised should probably go to a treatment center. People who have mild disease and can manage their care could be sent home. But if they're living in a situation where there's no way they can separate from their family members, then maybe that needs to be rethought, or there isn't the supports that are needed. They don't have community health workers that can go in and support. Then maybe that needs to be rethought, and they do need to be admitted to a treatment center. So it's a complicated issue, and we are trying to to look for ways to support people in home, because we know the health systems in some countries are getting overwhelmed. So we have to find that balance, right? We can't have our health systems overwhelmed with no places to care for patients and the really sick patients by not putting people at home. So it's really, each country has to make their own decision and look at their situation and look at all of the recommendations around home care guidance and whether or not we can they can manage it. And we also have to remember that, I know he spoke to COVID, but we have to think about the mode of transmission is a little bit different here as well, right? So the mode of transmission primarily for mpox is that close contact. So if you're not touching the person and their lesions, then your risks are much less. Whereas with COVID, there's coughing, sneezing, there was droplets in the, and it's a little bit different, and it's harder to separate people from something like that. So we have to think about the mode of transmission in the case of mpox as well, which will impact those decisions. And I don't know, April, if you want to add anything.
Yeah, no, I think really good comprehensive response, Vicky. And I think the only thing to add, as you were saying about the modes of transmission, is also to think about the disease itself. I think one of the challenges with mpox is that it takes a long time for the lesions to heal. As colleagues know, it can take anywhere, between 3 and up to 6 weeks for the lesions to heal. So keeping people in hospital for that amount of time takes up, as you say, a lot of resources. And they generally, particularly after a few weeks, are feeling much better. So they often, it's also, they don't want to be staying in hospital. So I think you have to consider that side and balance all of those. And as you presented earlier, Vicky, for colleagues, they can look at is there's also the option of if they're at home and they cover their lesions and they make sure they do good cleaning and disinfecting. This is also preventative measures for onwards transmission. So I just wanted to add that. Thank you very much. And back to you, Landry.
I just wondered if Pierre-Yves wanted or Nosheen wanted to add anything. Yeah.
Yeah, thank you so much, Vicky. Just one point on the shared toilets. I think that was a really good comment on the type of toilet. I think if there is no contact of the infected patient with this toilet seat, if the person is using a toilet seat, then definitely it has to be clean and disinfected after each use by the infected person. Or by the caregiver using the appropriate PPEs. If it's a squat toilet, then routine cleaning and disinfection is important, not after every use, but generally to keep the space clean. So it's as April and Vicky has mentioned, if there is no contact of the infected patient with the surface, then there is no need for intensifying the cleaning and disinfection after every use of the toilet. Yeah, I think that was also an online question. Over to you, Pierre-Yves, if you have any additional comments.
No, nothing to add really on the concept. Maybe just on the operation, just to mention that in DRC, in Burundi, where we've got most cases, we are not seeing a lot of home care, of people being treated at home for now. It is changing a bit in Burundi, and we have more and more people being treated. The intervention we have in Burundi is more a double aspect. Is first to give a package of supplies for the family at admission, and then a discharge kit when the patient goes back home, because the patient usually goes for a certain time in the healthcare facilities. There are discussion about how long patients remain in the healthcare facilities before going back home, and we see some change because of the burden on the hospitals. In DRC so far, we only had discharge kits provided, and I think we had 2,500 families supported with discharge kits so far, but we are not seeing a strong interest for home care, despite the burden on the healthcare system and the issue we have with the number of patients in healthcare facilities. So I think it is also something that is moving, and that is where this guidance is also useful for youth professionals in the field to take the right decision about how we can manage patient at healthcare facilities versus home care. Thank you, and back to you, Landry.
Thank you so much, Pierre-Yves. Let me just summarize this question or the responses from the panelists in French. Je vais juste donner un petit résumé rapide sur ce topic. Donc, premièrement, Vicky a mentionné l'importance de faire une évaluation. Avant d'admettre la prise en charge à domicile, il faut faire une évaluation. Et l'évaluation est d'abord clinique. Il faut que le patient ne soit pas un cas sévère. Il faut que le patient n'ait pas un risque de sévérité. Par exemple, un patient immunodéprimé et tout, âge moins de 5 ans, etc. Donc, il faut cette évaluation en rapport avec la sévérité. Deuxièmement, il faut une évaluation en rapport avec le ménage lui-même, la maison. Est-ce qu'il y a une facilité d'isoler un patient de la maison? Si ces critères-là ne sont pas remplis, il ne faut pas conseiller le traitement à domicile. Et puis, il y a aussi ce que Pierre-Yves a dit qui est très important sur ce qui se passe actuellement en RDC et au Burundi. C'est plus les traitements dans les établissements de santé et très peu ou presque pas, surtout en RDC, le traitement à domicile. Et que les patients hospitalisés, c'est lorsqu'ils sont déchargés qu'ils obtiennent des kits d'hygiène avant de rentrer dans leur domicile. On va donner la parole à José pour un dernier commentaire sur ce sujet. Et puis, on prendra une dernière question avant de clôturer. Mr. Jacker, can you please help us to give the floor to José Lolekolelo for a follow-up comment from his side? Oui, allez-y, José, vous pouvez prendre la parole. Vous pouvez activer votre micro, s'il vous plaît. Entre-temps, Lassina, s'il te plaît, regarde s'il y a une dernière question que nous allons prendre. À vous, José.
Oui.
Oui, il y
Là,
a
je
une...
peux attendre. Là, c'est
Oui,
bon?
oui, allez-y, José, on vous entend.
Oui, merci. Je sais qu'il y a des critères. Là où j'ai aimé, il dit critères de voir à la maison comment ça se passe. Oui, c'est vrai. En RD Congo, beaucoup de patients, on les prend en charge à domicile. Je pense que si et seulement si, les endroits où les soins ne sont pas gratuits par rapport à mpox. Si et seulement si, on a eu à libérer les malades selon le consentement des cliniciens. Cette évaluation, même pendant les mpox, même pendant le Covid, on le faisait. Mais c'est seulement le comportement à risque. Quand les malades commencent à se faire guérir, mais les germes contaminent souvent les autres. Pour le malade qui est libéré, il n'y aura pas de problème. Mais c'est l'entourage qui sera contaminé. Mon problème, c'est à ce niveau. Comme la situation est encore sous contrôle, je pense que c'est mieux qu'on puisse encourager à ce qu'on puisse libérer les malades après guérison. Dès qu'on voit que le malade ne peut plus contaminer, c'est là qu'on peut libérer le malade. Prenons quelqu'un qui est en fait homme à l'âge de majorité, donc qui peut avoir ses spermes et consorts, il peut s'accoupler avec sa femme et qu'il peut la contaminer. Est-ce que tout le monde accepte l'utilisation des condoms ou bien l'utilise convenablement? Tout ça, ce sont des comportements à risque qui fait que même si on laisse à domicile, est-ce qu'il y aura respect de ça? Mais quand on voit qu'à telle période, même s'il y a les germes, mais ce n'est plus contaminant, on libère le malade. Je pense qu'avec ça, ça pourra être bon. étant donné que la maladie est avec nous dans la communauté. Et souvent, dans la communauté, il y a ce qu'on appelle la croyance. On va dire que non, ça c'est une maladie, peut-être c'est la tante qui a fait que ça soit. C'est ce qui aggrave la situation chez nous à domicile. C'est ce qui aggrave la situation, la croyance. Ce qu'il a dit, oui, il y aura des critères d'évaluation et consorts, mais c'est difficile à convaincre. Vous êtes comme moi, vous le savez aujourd'hui, avec des soi-disant médecines, si c'est amélioré. Ils sont en train de crier partout à la radio. D'autres qui disent que non, ils connaissent se soigner les mpox. C'est bon, mais quand est-ce qu'ils ont découvert les mpox? Ils ne connaissent même pas les critères. Malheureusement pour eux, ils se contaminent aussi à masse. C'est soi-disant les médecines améliorées là. Moi, c'est un peu dans ce sens que je pense. Je croyais que si quelqu'un est contaminé, pour garder la performance de la PCI de l'hygiène, on garde à l'hôpital l'itinéraire des malades, on désinfecte selon les critères recommandés. Avec l'équipe de surveillance, on voit s'il y a d'autres cas à domicile ou s'il n'y en a pas. On va repasser peut-être 2, 3, 4 fois pour voir s'il n'y aura pas d'autres cas. Mais celui qui est retenu à l'hôpital, on le prend en charge et d'une façon alimentaire et d'une façon médicale et d'une façon PCI et d'une façon psychologique. Et une fois qu'il est guéri, et on les remet déjà guéri. À ce moment-là, nous allons limiter la propagation. Mais si quelqu'un à domicile, par exemple, il a sa maison, il a sa toilette interne, il n'a personne avec lui, il vit seul, il peut se servir lui-même et que ça peut passer, il n'y a pas de problème. Ce qui est difficile chez nous en Afrique, ce qui est difficile de trouver des cas pareils. C'est un peu dans ce sens que je veux dire.
Oui.
Voilà.
I think, avant José, s'il te plaît, vous êtes en RDC, c'est ça? Dans quelle province ou ville?
Oui, je suis en RDC. Je suis médecin de l'hygiène et salubrité publique dans la province du Haut-Ouélé. Je m'occupe de la PCI, je m'occupe de tout ce qui est épidémie, riposte pour PCI, pour ceci. Ça s'est fait avec nous. Mais ce que je vous parle, c'est du vécu. On a expérimenté à l'époque de Covid, mais curieusement, ça a permis la propagation. Même jusqu'aux plus petits enfants ont été contaminés avec ces soins qu'on renvoyait à domicile. L'individu évolue bien avec les médicaments et tout ce qu'on a donné, mais il est en train de contaminer les autres. La litérie, tout ça, vous allez trouver, même il couche en 2 personnes. Voilà, on trouve qu'il est venu à l'hôpital, donc c'est fini. D'autres vont dire que non, c'est la sorcellerie. C'est autant de choses. Ce qu'il a dit, c'est vrai, mais ici, c'est du vécu, c'est le terrain. Je pense que si on peut adapter la situation à ce moment-là, ça pourrait être la même chose. Tout comme il a parlé, l'autre a posé la question sur les enterrements dignes et sécurisés. Eh bien, c'est la même chose. Donc, si quelqu'un meurt à l'hôpital, vous saurez contrôler la situation. Hein? Vous saurez contrôler, mettre dans le cercueil, faire ceci avec la famille. Mais si la personne meurt dans la communauté, c'est difficile de réglementer. Il risque de vous créer des problèmes. Donc, tout ça, notre communauté ne nous permet pas encore d'exécuter des mesures pareilles.
OK, thank you. Merci beaucoup. Dis-moi un peu, le Haut-Ouélé, le mpox, est-ce que c'est endémique ou bien ils viennent d'avoir des premiers cas depuis 2022 ou bien c'est depuis des années?
Depuis 2019, on a toujours déclaré des cas, mais l'épidémie n'a jamais été déclarée. 2019-2023, il y avait même 4 cas confirmés par l'INRB. Et c'est à 2024 ici qu'on a eu déclaration générale du pays. Et jusqu'à aujourd'hui, même hier, il y a eu des cas validés qu'on a eu à prélever les échantillons pour envoyer à l'INRB et ainsi de suite. Et vous savez, nous sommes entourés aussi de réserves de parcs. Il y a le parc national de Garamba où il y a tous les animaux qu'on suspecte avoir les mpox, il y a réserve de Pengue, il y a réserve de faune à Okapi qui est entre l'Ituri et le Haut-Ouélé. Donc, ce sont des choses pareilles où nous sommes en train de vivre. Et au moment où je vous parle, je suis sur le terrain entre Dungu. Donc, Dungu, c'est là où se trouve le parc de Garamba. Et voilà, on est en train de sensibiliser, on est en train de faire ceci. Donc, il y a le problème de mpox. Et bien sûr, on n'est pas encore équipé, hein, on n'a pas de kit PCI pour bien riposter à la chose, mais avec la sensibilisation, avec ce que l'hôpital a d'avance, nous sommes en train d'isoler les malades et les prendre en charge comme tels. Dès qu'on voit que vraiment il n'y a plus de problème et qu'on sort et on libère. Et là, nous sommes en train de bouillir. Donc, les habits, la literie, tout ça, on s'occupe et on met dans son sac et puis on les libère avec des instructions sur ceci, cela, et s'il y a ça, et puis ils reviennent. Mais on ne voit pas aussi ces familles être contaminées par celui qu'on a eu à libérer de l'hôpital. Vous voyez là où nous sommes contents?
Ouais.
Voilà, c'est là où nous sommes contents.
OK. José, si vous pouvez, je ne sais pas si vous êtes en contact avec le point focal PCI national de l'OMS, mais j'encouragerais, il s'appelle Dr. Raphaël Okoum, j'encouragerais que vous
Oui.
puissiez.
On
OK.
Docteur Raphaël, c'est un monsieur très compétent et il nous suit à la loupe. Il suit notre situation, il appuie fermement la direction de l'hygiène. Nous avons plusieurs conférences avec lui. Je ne sais pas si celle-ci, docteur Raphaël est dedans, mais c'est un
Ouais, il
monsieur
est
que
dedans.
j'ai beaucoup.
Oui.
Voilà, j'ai beaucoup
Oh,
d'estime comme membre de la PCI. Je pense que c'est bon, c'est bon.
Oui,
C'est le
je
bon.
vais
Ce n'est pas dans ce
résumer
cadre
ce
de
que vous avez
continuer.
dit, hein. Je vais résumer
Oui,
ça aux collègues panélistes sur
oui.
the challenges that they have there in DRC in Haut-Uele is that there are risk behaviors from people who are infected with mpox. If you try to take them care from home, they always have behaviors at risk, and there are lots of rumors from the community, especially from the traditional healers who are saying that they are able to treat mpox, etc., etc. And so they have experienced a lot of transmission in the households when the patients were isolated, were taken care at home. And therefore, in Haut-Uele, they are not recommending home care. They are treating all the patients in the hospital, and when they are ill, they send them back after disinfecting all their belongings. So this is the challenge that they have faced of these of the community when they need to sensitize them a lot so that to get good results. But otherwise, right now with the knowledge and the rumors circulating in the community, it's really challenging to take care to the patients from home. So we have gone, we have exited, we have gone, we are supposed to finalize this webinar 20 minutes ago, but please allow us to get two more comments from one from Augustine and the other one from Lassine. Let's start with Augustine and then we'll go with Lassine. Augustin, à vous la parole. Augustin, je ne sais pas, il a Lassine.
Disconnected.
Yeah. Lassine, vous pouvez prendre la parole, s'il vous plaît. Can you take the floor, Lassine? Vous pouvez activer votre micro, Lassine, s'il vous plaît. OK, allez-y, Lassine. Bon, OK. Oui, allez-y, Lassine. Maintenant, vous pouvez parler.
Ok. Merci. Moi, c'est Dr. Kamara Lanchine. Je suis à Conakry. Je suis au compte de la Direction nationale de l'épidémie de la lutte contre la maladie. Je suis un agent de contrôle sanitaire à l'aéroport. Ma question qui est là, nous sommes au niveau du contrôle sanitaire. Il n'y a pas de dispositifs qui sont mis en place. Maintenant, je demande quel conseil ou bien quelles précautions il peut nous dire pour qu'on puisse mettre à notre à l'arrivée de à l'aéroport ici. Parce qu'on a les caméras thermiques, on ne fait que de visualiser la température des passagers. Mais il n'y a pas de dispositif concret. Et comme nous sommes dans une période d'épidémie, je demande quelques précautions qu'il faut pour prendre ici, pour mettre les dispositifs en place. C'est un peu ma question. Je vous remercie.
So, Lassim's questions, I don't know, April, if you got the question, is about the point of entry, especially the airport. They just have the camera, thermic camera, but there is no any other, they don't screen at the airport, so I think no anti-hygiene. So I don't know if he asking what would be the recommendations. Yes, Vicky.
Hi, sorry. We don't have a lot right now. They are recommending some screening, but it's a difficult thing, right? You have to look for actual presence of lesions and other symptoms. So temperature screening alone is probably not going to be sufficient. We do have some guidances and we can send it out around points of entry, but we know that it is a challenge for many areas. And while in particular, we know it's a little bit easier to implement in airports, the main concern is really at the borders, the land borders, where we're seeing issues with the capacity to screen people coming between countries, and that in many countries where there's shared borders, people are traversing them daily or regularly. It's just part of their normal day-to-day process. So we have recommended some screening procedures, but we certainly understand there's a lot of challenges with that. And you know, again, temperature screening alone is not sufficient. We have to actually be asking the people if they have lesions or any other of the signs and symptoms. So they could certainly use some of the tools and there is an existing guidance document for that from the department that does points of entry. And I think with that, Landry, we should wrap up because I know all the panelists, we have other meetings we have to go to.
Yeah, sure. Yeah. Augustin, juste 30 secondes pour toi si c'est un commentaire et puis on va conclure.
Ok, merci, c'est Augustin, focal PCI pour le site qui voit RDC. Et bon, je voulais seulement rassurer les recommandations, donc les observations qui ont été émises par mon collègue qui est au retour là-bas. Donc, pour dire qu'en tout cas, l'isolement à domicile, c'est une question qui nécessite quand même qu'on ait des bonnes orientations, vu que dans la contextualisation et dans les conditions qui sont les nôtres, en tout cas, c'est une question qui nécessite d'avoir beaucoup plus d'orientation et surtout des éléments qui sont concrets, par le fait que les comportements de la population ne permettraient pas à ce que ce soit une décision facile. Moi, ce que je pourrais proposer, c'est que quand même dans l'isolement à domicile soit quand même quelque chose à cas de force majeure, soit que l'on n'a pas de l'espace d'isolement au niveau des structures de prise en charge, ou par exemple, s'il y a une forte résistance, c'est à ce moment-là peut-être qu'il fallait passer à l'isolement à domicile, vu les contextes, les comportements, les conditions de ménage dans lesquelles nous avons, les malades qui, des fois, sont obligés d'aller, par exemple, débrouiller puisqu'ils vivent du jour au jour. Vous allez isoler quelqu'un, je me souviens, il y avait un enfant qu'on devait isoler, il y avait un cas qu'on a observé dans un des centres de traitement où, par exemple, quelqu'un qui vous dit, je suis à la maison seul, je n'ai pas personne et c'est mon enfant qui est malade, qu'est-ce que je peux faire à un certain moment? C'est peut-être dans ces conditions-là, mais moi, je pense que dans la mesure du possible, si on peut avoir un endroit pour l'isolement, en tout cas, je conseillerais que peut-être l'isolement dans le centre de traitement soit prioritaire et qu'au cas où on n'a pas maintenant de moyens d'isolement, c'est à ce moment-là que donc essayer de serrer cela peut-être dans les critères quand même d'isolement. Donc c'était une petite observation que je voulais seulement ajouter. Merci.
Merci à vous, Augustin, de renforcer ce que José a dit. And thank all of you for joining us today, for this contributing to such an engagement and productive session. So throughout the webinar, we have explored a lot of knowledge and practical tools essential to scaling up infection prevention and control and water sanitation and hygiene measures in the response to mpox outbreak. So I'm going to quickly give some key takeaways from our discussion. Lassina Soro highlighted the comprehensive IPC and WASH measures necessary in healthcare facilities and community settings. And these include clinical and IPC guidelines, screening tools, training materials, and resources for home care, cleaning, and disinfection. He also discussed a little bit around the integration of these measures across settings like schools, congregating environment, IDP camps, etc. And then Noshin provided some critical insight into environmental health standards in healthcare facilities, emphasizing on the tools from the WASH feet, but also the self-management of infectious waste, sharps, and the importance of maintaining essential water supply and disinfection standard. Vicky brought to our attention the IPC consideration for managing mild cases at home, emphasizing on the tools such as the one of decision-making algorithms, and also the infographics for caregivers and individuals, as well as the essential supply list that has been developed to support the home care. She spoke as well. She addressed the IPC WASH requirements for vaccination activities, IDP camps, underlying the importance of clear public advice and preparedness. So these highlights reaffirm the cross-cutting nature of IPC WASH measures in protecting health workers, patients, and communities, and they showcase the robust set of tools and resources WHO and our partners like UNICEF, Africa CDC have worked on and developed to support countries in effective managing mpox response. I'll therefore would like to express my gratitude to our distinguished speakers and panelists, and for their valuable contribution. Their expertise and perspective have greatly enriched our discussion. Thank you for your dedication and participation. To all the participants. We had over 170 participants, and please stay connected with us and feel free to reach out with any question and request for additional support. We'll make sure for everybody who participated to this session to share all the material that have been developed so far and that have been finalized and approved by the WHO. Thank you so much and have a great day and end of the year. Joyeux Noël, bonne année. Bye-bye.